Thank you, Björn. Thank you, Lothar. Hello. And I'd like to come a little bit closer to quality of life theme, which is very interesting and which is my daily life in the outpatient care department, talking about pregnancy. Even I'm not an obstetrician or gynecologist. I'm in this daily practice of talking with patients with congenital heart defects concerning pregnancy. Why do we do this? Here are the numbers, and I think it's clear because you see that we have increasing numbers of adult patients even in complex anatomy. And these patients come and ask us, can I become pregnant or not? We have two groups. The first group is the groups with the atrial switch patients, which are about 30 to 35 years old. And the other group, I don't know why this happens now. Okay. It was not. Okay. You know what? There should be a picture. I'm sorry. I checked it, but now it's coming up like this. These are the arterial switch patients, which are about 20 to 25 years now. And to come a little bit more closer into this theme, I think I have to give you the most important information, what happens in pregnancy. First of all, you see here in the upper graph the blood volume of compared to normal control women which are not pregnant, and what happens in pregnancy when you look up for the gestational weeks here, you see a huge increase of plasma volume, less in the erythrocyte, and the total blood volume comes up to 40 to 50%. We have a volume overload. And the second is the cardiac output. It's nearly the same in percentage, which is starting with the start of gestation after conception, that you have a cardiac output increase until the end of pregnancy up to 30% compared to normal cardiac situation. And this raises two questions. One question which we address to the atrial switch patient women, is the systemic right ventricle able to increase cardiac output during pregnancy? And in the other group, for the arterial switch patients, are the reinserted coronary arteries able to cope with the increased myocardial oxygen demand? And I try to give up my information to you. It's not a lot, as always in this patient group, because we don't have numbers like the cardiac population with acquired disease, but we have a few information concerning this group with the atrial switch operation. I don't want to repeat everything which is written here, but to look, these are the problems without pregnancy, and now we come to a special situation with pregnancy and what will happen. I love this working group from the Netherlands. Probably somebody of the group will be here from the Drenton work group. They have a lot of experience concerning all kinds of different heart defects, and I want to show you they did this publication nearly 5 years ago, where they did review work over 20 years, starting in the mid-80s till 2005. And they reviewed all the papers which were written. It was a huge work that was performed. And there were 2,500 pregnancies in total. And in the group we are interested in now, in the TJA group, there were nearly 180 patients which were ruled out by, I think it were 13 publications. And this is the overall outcome in this patient group. And as you see here, this is expected normal pregnancy woman without any congenital heart defects. We have the miscarriage group here, and this in the normal population about 10%. In the TGA group, it's a little bit more, it's up to 15%, but most of them, like expected here, complete their pregnancy. So I can stop my talk now and say, okay, everything will be fine. No, it's not like this. It's a little bit more complicated. To give you the idea, I try to divide this in 3 parts. The cardiac complications, and you see here the TGA group yeah? Compared to the expected group, we have here the arrhythmias. They deal with problems of arrhythmia. Most of the patients in these publications were, of course, Zenning or mustard patients, and we have, on the other hand, the heart failure due to the right systemic ventricle in this group. And you see expected, they really have, and this will be the next slide in numbers. Here is the number of 173 patients where here inside they suffer from arrhythmia, most of them from supraventricular arrhythmia, and they suffer from heart failure, as you see here, which is given up there. Yeah. And coming up to the next aspect, the gynecological aspects, here you see the TGA group. Compared to the expected, we have hypertensive disorders in the normal population of nearly 10%, and here, which is much higher. Nobody knows exactly why it is like this. There are several aspects which are anticipated. One of the problems of these patients suffer from is preeclampsia. This might be due to nulliparity. This might be due to reduced placental flow, to activation of neurohormonal pathways. This is what I read, but I'm honest, I can't really explain it to you. You should know this, even if you care after patients, that you have to look after this. The gynecologists and the obstetricians you work with, they should also know. Of course, they are aware of this because they also deal together with us for this patient group, but it's not quite clearly known why this is like this. And the other thing you see here is the high rate of premature labor. We also don't know why, and speculations are that in these patients they suffer from premature rupture of membranes. This is what I found, but in the moment it's still unclear, and it's just the information I can give to you. And on the fetal side, you see the complication due to the premature labor. Of course, here you see the premature delivery. If they have premature labor, they deliver even earlier compared to the expected group of a little bit more than 10%, which comes up to nearly 40%. It depends on the publication you read. And on the other side, you see babies which are too small. They have a birth weight less than on the 10th percentile, and this might be, in my opinion, explained by the reduced placental blood flow due to the reduced cardiac output these patients have. The reoccurrence rate of congenital heart disease was overall, the publications, about 0.6%. Now I looked to the special literature, and I don't want to bore you. I just want to highlight two publications which looked a little bit more deeper. This is a publication from an American working group from last year, and they looked, you see here, for 25 women. These were patients with atrial switch operation. They had an extremely high preterm birth of 50%, and they had, this was also very high in comparison to the other publications, a high incidence of intracardiac baffle obstruction. Yesterday I just looked, did they have all the mustard procedure? No, they didn't write it. I can't answer this question. And they looked to the right ventricular function, and this is why I want to present this publication to you, because it's it's a single publication where they looked after the right ventricular function by dP to dt, and normally you have this value for the left ventricle with normal values of 1,000 to 2,000 millimeters of mercury per second, and as you see here in the pre-pregnancy group, these are a little bit lower, decreased during pregnancy. That means they have an impaired right ventricular function and come back after pregnancy, but not to the values compared to the beginning. Another work which is a little bit older, from 2004, looked after the right ventricular function as well. Don't worry, I don't want to talk about everything. I just want to demonstrate that the degree of RV dilation was 38% after the pregnancy. They didn't come back to the normal values compared to during and before the pregnancy. And the RV systolic dysfunction also, where nearly 20% stayed in this worsened status after pregnancy. So even if most of the patients go into pregnancy with a good functional class, you can't say to the patient everything will be fine. They should know that there's a high risk of staying in a less cardiac function after pregnancy. There were no maternal deaths. And now I want to present not but it's a multi-center study with Munich and Zurich together with 35 women and 60 pregnancies. Half of them had mustard and Zenning operation. Nearly half and half were complex and isolated. All of the patients were in good functional class, as you see here, most of the patients and 50% in functional class 2. And I want to give you up the information. They all are nearly the same. They only differ in the high of the percentage, but we almost find the same complications. As you see here, 9% had serious cardiac events during delivery. 2 of them needed resuscitation, 2 had severe cardiac decompensation. 21% were in functional class deterioration. 14% had progressive RV dysfunction without improvement. This is what I already showed you in the other works. 8% have progressive regurgitation without improvement. There was 2%, one patient here, with progressive SV obstruction, and 3 patients with a buffer leak, which became evident during pregnancy. The gynecological aspects, where I try to go a little bit quicker here, we had 16 abortions, 5 were induced, and 11 were spontaneous. There was a huge rate of C-section, and 1/3 of these patients want to give birth to the child by C-section without any cardiac or obstetrical reason. This was the wish of the women. I think you should know this because we normally don't recommend C-section in these patients. And as you see here, 9% had premature rupture of membranes. To the fetal aspects, 25% have their babies with premature birth. There were no cardiac defect in the infants, and as I already told, we had a high rate of small for gestational age babies. So you see, if you take this study or this study, the problems are nearly all the same, and they are, I missed the word in English, wiederholbar. So they are repeatable, they are, yeah, you understand me. Okay. Now, in conclusion, to close these atrial switch patient, I can say the pregnancy in these patients may be successful, but you have to tell the patients that they should know that there might be a decline in the right ventricular function. Yeah, this should be anticipated. They carry a risk of RV dysfunction without any recovery. It's interesting, or you should do imaging for buffer leak obstruction with consecutive therapy before pregnancy. I think this is necessary if you know that nearly 40% might have this during or before pregnancy. And affected women should be informed roughly about potential risk, meaning the risk for the fetal and of the premature birth, and they can make the decision with you if they become pregnant or not. Now I have only few information concerning these patients because they are not pregnant in the moment. So they should be pregnant, but they are not, and I can give you only few information. That means I can tell you it like a story that there was a publication in 2007 for one women who had absolutely fine pregnancy, and this was a publication by the from 2010 by the Toronto Working Group together with the Boston Children's Hospital, and they looked for all the women in childbearing age. These are 74 women, and in a time period over 10 years. And it was a very early cohort of patients, and they had 9 patients with 17 pregnancies. And if you read this, I can give you this summary. There were nearly 70% of these patients which had a re-intervention before they became pregnant. And this was due to the early cohort. Some patients had a conduit operation, a 2-stage operation, and therefore they needed, before they became pregnant, a second operation, or they need an intervention due to a catheterization. There were 24% of miscarriages, and 15%, these were in number 2 patients who developed cardiac complications during pregnancy. One of these women was a woman who needed a mechanical mitral valve replacement, and she suffered from thrombosis. I think this is absolutely something else from the arterial switch operation, and the other one had impaired left ventricular function, and she had VT during her pregnancy. But this is interesting what will follow. They did not find any myocardial infarctions. They did not see a significant increase in aortic root dilation. They had no maternal death. They had no preterm deliveries. Remind what I talked about the other patient group. They had no SGH babies. They had no fetal and neonatal death. And I think that's only 10 patients, but in a small group, but this seems to be a really much more better group. And if you make a short conclusion of this, you can say data are rare, but we have less intra-atrial manipulations, therefore less rhythm problems. We have a morphologic left ventricle in this patient. That's absolutely different. We might expect really less cardiac complication, and we don't know about myocardial infarctions. And I think yesterday we had an interesting discussion about, do we need to look after the coronaries in these patients? I would say we need, if they want to become pregnant, because this will be very useful information to do in front of a pregnancy, even if they become problems in the pregnancy then. So if you take both women groups together, you can say for both women groups that if the pregnancy is well tolerated, spontaneous delivery can be performed. C-section is absolutely not necessary, or the women like to have C-section. That's another question. You don't need a special monitoring. I think non-invasive monitoring, which means blood pressure measuring, ECG, pulse oximetry, is absolutely adequate in good systemic ventricular function. And if you have a status with deteriorated cardiac function, probably an intra-atrial line in a big clinic is very useful. One sentence to the risk stratification, which is another point of view to view at this patient group. If somebody comes to you and say, what about my risk? There are 2 publications I want to mention until I come to the end of my speech. Is the publication, which is nearly 10 years old now, from the Toronto Working Group. They looked after 562 pregnant women, acquired and congenital heart disease, and they did a risk stratification, it's so-called CO score. And if you look at the CO score for cardiac risk points, you see prior cardiac events or arrhythmia, severe functional class or NYHA functional class over 2 or more, or cyanosis, left heart obstruction, and systemic ventricular function with an ejection fraction of less than 40%. You can score the patients and give another kind of recommendation. And another very important work was performed by the Drenthe work group from the Netherlands. I already showed at the beginning of my speech. This is a retrospective study. They classified these risk factors and they give points. You see, you can give the points, probably a woman presenting with arrhythmia, as Katja told me, and she had cyanotic heart disease corrected, but she would have a point here, and she would have probably, I don't know which New Year class she was, but she would have 1.5, and 2 points means 2.5, and she would be stratified in this group, meaning that she will have a cardiac complication in percent of 70.5, yeah, to have a complication during her pregnancy. And this is another help to give the information to the patients what will happen with them when they get pregnant. So I summarize now. Pre-pregnancy counseling should be performed on actual cardiac and obstetrical data. That's very important. It doesn't bring anything if you say the patient 2 years ago everything was fine. You need really actual documentation concerning Holter ECG, MRI, echocardiography, and then you can do the risk stratification. Cardiac interventions or operation, even necessary, should be performed, of course, before the conception, and pregnancies in women with TGA should be managed together with the obstetricians, probably in a good center. Thank you.